So you can start.
Yeah. Very good afternoon to the chair, and thanks the organizers for the opportunity. Today I'll be walking through a case of extraordinary case report on a cardiorenal syndrome and its ocular manifestation. We'll first understand what is cardiorenal syndrome. Cardiorenal syndrome encompasses a spectrum of disorders involving both heart and the kidney. Acute or chronic dysfunction in one organ induces acute or chronic dysfunction in the other organ. The eye shares similarities with the kidney, suggesting that kidney disease and ocular diseases may be closely linked. If you see on the flow chart on the right side, you see those white and light blue color arrow that says that the triggers which are there, maybe smoking, dyslipidemia, glucose increase, increased blood pressure, thereby leading on to an endothelial dysfunction. That translates into the microvascular dysfunction in the form of reduced vasodilator response, increased platelet activity, rarefaction, remodeling, and fibrinolysis, leading on to the end organ dysfunction and damage. Mainly on the kidney, it can reduce the GFR, leading on to albuminuria. On the heart, it may lead to coronary artery disease, left ventricular heart failure. Brain, it can cause stroke and small vessel disease. Eye, what we are concerned, it can cause retinopathy or choroidopathy. Understanding the pathomechanism of the cardiorenal syndrome, you see the oxidative stress and inflammation. There is upregulation leading on to renin-angiotensin increase and the increase in the sympathetic nervous system, which in turn reduces the natriuretic peptide, reducing the nitric oxide secretion, increased wall thickening, and reduced elastic fiber in the endothelium, thereby causing on vasoconstriction, increased vascular resistance, plaque formation, and venous congestion. This translates into increased sodium transporters, extracellular matrix deposition increase, leading on to decreased renal perfusion, decreased renal output, and sodium retention. On the heart, it will lead on to increased myocyte hypertrophy, increased extracellular matrix deposition, reduced myocardial perfusion, and cardiac output. That was for cardiorenal syndrome. Because vascular for this thing is also there in the eye, similar changes can happen in the eye, which I will be enumerating in the subsequent slides. We go through a case report. We had a 28-year-old male patient who was a plumber who was having diabetes mellitus type 1 since 12 years. He was also having decompensated cardiomyopathy, which was diagnosed since 2 years. He had a chronic kidney disease since 1 year, and recently he was diagnosed to have cardiorenal syndrome. The patient was referred for a routine eye examination. Patient had no specific eye complaints. On evaluation, right eye vision was 6.9 NAP and 6.12 with pinhole improving to 6.9 in the left eye. Anterior segment was unremarkable. Going on the fundus photography, both the eyes had proliferative diabetic retinopathy changes, grade 2 hypertensive retinopathy changes. On the right side, you see the pre-retinal hemorrhages along the superior temporal arcade, which is bled from the proliferations. Going on to the OCT findings, it was unremarkable, but for those hard exudates, and there is no RNFL changes. Coming to the discussion, diabetes and cardiovascular disease go hand in hand. Alteration in microvascular structure and function contributes to disease progression to involve eyes, kidney, and heart. The glomerulus present in the kidney and the choroid have extensive vascular network of similar structure. The inner retina and the glomerular filtration barrier shares similar developmental pathway, and renin-angiotensin system hormonal cascade is found both in kidney and eyes. We are at advantage for the reason that we can directly visualize the microvascular changes in the retina, which reflects in turn similar changes occurring in cardiorenal syndrome. As we go on to the panel down, you see the kidney and the eye both has fenestrated endothelial network, and in the eye you have the Brooks membrane. In the kidney you have the glomerular basement membrane and the podocyte in the kidney, whereas we have the retinal pigment epithelium surrounding the endothelium, the fenestrations. So to conclude, there is an upregulation of the humoral signaling leading on to cytokine secretion, leading on to solute free water excretion and sodium excretion. This in conjunction with the aldosterone and atrial natriuretic peptide and arginine vasopressin and the sympathetic pathway it leads on to what is called as the peripheral vasoconstriction. In the heart, it can cause ischemic cardiomyopathy or arrhythmias. In the kidney, it can cause renal hypoperfusion and causing tubular toxicity, decreased GFR, decreased oxygen delivery, diuretic resistance, necrosis, apoptosis, and organ edema. As far as eye is concerned, on the bottom panel you can see there is endothelial damage leading on to the vasoproliferations, and that can lead on to bleeding. On the contrary, OCT angio can show the vascular dropout. As we can see in the normal one and the CKD patient, there is CNP areas. Thus, to conclude, the importance of eye examination in a case of cardiorenal syndrome is emphasized, which helps to timely diagnose and manage the patient. This patient, we had advised the PRP and follow. Thanks for the opportunity.
Thank you, sir. I wanted to ask, labeling the patient as cardiorenal syndrome, does it change anything in the management? Because it looks like a proliferative diabetic case to me.
Yes, sir. This patient, if you know, sir, because the patient was asymptomatic, sir, it was referred elsewhere from being diagnosed as cardiorenal syndrome. And once we had a look into the fundus, we picked up all these changes. So we should be mindful of ocular changes in a case of cardiorenal syndrome. And the duration of diabetes is hardly 1 decade, sir. And as we know, it takes much more longer time for this much of proliferation and bleeding to occur. So maybe there is an early proliferation and the bleed in these patients.
I can see there was vitreous hemorrhage. There was some hemorrhage in the right eye, but patient was asymptomatic.
Yes, sir, because the central area was normal. 6/9 vision in the right eye and 6/12 improving to 6/9 in the other eye.
Okay, thank you.
Yes, thank you.
Next presenter, please. Dr. Prerna Ahuja, please come on the dais.
Good afternoon, everybody. My topic is ocular presentations in leukemia, and I'll be talking about a series of around 6 cases. So the first case is of a patient of ALL, and it was a T-cell ALL patient presented with a severe headache, ptosis, with having bilateral 3rd and 6th cranial nerve palsy, loss of vision, PL minus vision, and pupil was fixed 6 mm non-reactive, and the fundus picture looked like a bilateral CRAO picture. On clinical diagnosis, it was said that there's a CNS infiltration of acute leukemia, and the patient was started on a protocol which basically consisted of prednisolone, methotrexate, vincristine. And after 2 weeks of follow-up, the visual acuity was seen to improve, and at 21 days, it was seen to further improve, and the pupils also became reactive. And fundus, the hemorrhages were seen to reduce. And correlationally, you can see the platelet count is status quo. It's almost 1,000 change. This is the fundus photo. The fundus photo shows multiple hemorrhages that are seen in the pre-retinal hemorrhages. Superficial hemorrhages are also seen, and hemorrhages there at the macula as well. The white infiltrate can also be seen surrounded by the hemorrhage. Coming to the next case, it's a patient who has ALL. Both eyes diminution of vision was seen, and pupil were briskly reactive to light. On fundus examination, beautiful pictures of bilaterally presenting vitreous subhyaloid hemorrhage and superficial hemorrhages, pre-retinal hemorrhages could be seen. Macula was also involved in the right eye, in the left eye. Macula in the right eye also had a subhyaloid hemorrhage. Patient was started on IV antibiotics as the patient is presented with fever as well, and also packed RBCs were given, platelet transfusion was given, and patient was started on vincristine, methotrexate, and hydrocortisone, and the vision resolved to both eyes being 6/9. Case number 3, this patient presented with no complaints, no visual complaints, and on fundus examination, superficial hemorrhages could be seen in the superior and inferior temporal arcade, and whitish leukemic infiltrate type picture could be seen in the right eye. The next case, patient was a Philadelphia plus ALL chromosome on maintenance treatment and had multiple fever spikes. Patient also had features of ASOM, and on both eyes, vision was 6 by 6. However, the patient fundus was vitritis was present, and picture of retinal necrosis was present with hemorrhages along the inferotemporal arcade. Impression was made of having CMV retinitis and acute retinal necrosis with leukemic retinopathy. Unfortunately, the picture is not available for that. The next case, the last 4 fundus photos, as you can see, patient again had no symptoms. Only one rod spot could be seen in the superior temporal arcade and one just above the macula in the left eye. Case number 6, what is of relevance is both eyes superficial hemorrhages, pre-retinal hemorrhages were present and vision was dropped. Here also macula could be seen involved and whitish spot could be seen, which is an indicative of direct infiltration. Coming to the discussion part, it is imperative that leukemic patients have to be worked up for ocular treatment because 90% patients present with will have ocular involvement. However, only 50% will have symptoms. Now, acutely, they can present with anemia, hemorrhage, or infection, and chronically, they can have indolent features, vague symptoms. Most commonly, acute will present to you, and myeloid will have more common. Adults are more common, and in late stages, you will see fundus or ocular manifestations. Direct manifestations, we can see infiltrates. Possible leukemic infiltration with white-centered retinal hemorrhages could be seen. Hematological complications starting from subconjunctival hemorrhage going up to the last layer of retina hemorrhages can be seen. Opportunistic infections with CMV, herpes, mumps, uveitis, toxo can be seen. And secondary to treatment, that is vincristine and methotrexate, toxicity due to the treatment could also be seen. Now, direct manifestations can be whitish, grayish nodules, which could be small in size, and if the disease is fulminant, it could increase in size. Choroidal involvement, which is when there is serous retinal detachment, upon resolution, the detached retina, at the site of detached retina, there can be clumping of RP, so very classic leopard spot fundus can be seen. Subretinal infiltrates can also be seen, and vitreous opacity, such as masquerade syndrome, which could present like panuveitis, can also be seen. What is of interest is if the patient has a vitreous infiltration, it is likely that the patient will have a CNS involvement and a positive CSF tap, especially in the blast phase. Now, anemia will have, as I have already spoken about, anemia, thrombocytopenia, and hyperviscosity are the hematological complications, and the patient can have neurological complications of papilledema and veno-occlusive disease, as we saw in the first patient as well. If your patient presents to you with macular hemorrhage, and intracranial hemorrhage, we have to closely monitor, and patient has to be started on platelet transfusion. Coming to the treatment part, systemically, the patient has to be started on chemotherapy. Intrathecal chemotherapy can be indicated if CNS infiltration is seen. Cranial irradiation may be required. Ocular radiation, however, we have to keep in mind it can cause posterior subcapsular cataract. Blood transfusion, especially if the platelets, if the hemoglobin is low, and leukapheresis if the platelet count is very high. If the hemorrhages are not resolving, especially at the macular region, pars plana vitrectomy can also be seen. If serous RD is there, then also pars plana vitrectomy may be indicated. Thank you.
Thank you, Dr. Prerna. And all the patients which you have presented were already diagnosed.
Yes, so they were
With
all
all.
diagnosed cases. They were reference cases, basically, from the onco
this
center.
is in the tertiary case setup. You recommend that all cases of
Yes, sir.
leukemia, the eye examination should be done.
Yes, sir, because 90% and 50% won't complain of anything. Like in my case also, at least 50% of the patients didn't have any complaints.
So the
Visual
take-
complaints will only come in the later stage.
Yeah, so the take-home message is
All leukemia patients, ocular manifestations may or may not be present, but we have to do an ocular examination, including a fundus examination.
Thank you.
Thank you so much.
Next presenter, Dr. Chitralekha. Is she here?
Good afternoon, everyone, and thank you for this opportunity to discuss a very interesting case. This is a case of a 4-day-old term neonate admitted in the NICU with coagulopathy, thrombocytopenia, meconium aspiration syndrome, pulmonary hypertension, and hyperinsulinemic hypoglycemia. The child was referred to the ophthalmology department because a very observant resident in the NICU noted an abnormal red reflex in the left eye of the baby. So on day 4, when we examined the baby, the anterior segment examination was unremarkable and the fundus had these features. As we can see, this is the right eye showing proliferative retinopathy with vascular loops at the optic disc and looping of the peripheral vessels along with avascular retina in the periphery. So these images have been captured with the Zeiss handheld camera. So we can only capture 40° of the fundus. So this is the left eye. This had vitreous hemorrhage and this was the red reflex noted by the resident. The vitreous hemorrhage was seen nasally and over the optic disc while the peripheral temporal retina was visible and vascular loops were there, but that is again not captured in the fundus image. So this child then underwent a platelet transfusion on day 8 of life and we did laser photocoagulation to all the avascular area in the right eye. So post laser, this is again 3 to 4 weeks post laser in the right eye. We can see the laser area in the periphery and the complete resolution of the proliferation in the posterior pole. The left eye, because of the presence of vitreous hemorrhage, the laser was only partially possible in the temporal retina, again after the platelet transfusion. On follow-up, there was increase in vitreous hemorrhage. Then intravitreal ranibizumab was administered after the control of coagulopathy. However, the vitreous hemorrhage continued to persist. This child then went on to undergo an LSB under GA in view of the persistent vitreous hemorrhage. And when the surgery was being done, tractional RD was noted nasally. Post-operatively too, we can see these are the post-operative photos on follow-up that there is a nasal dry retinal fold. However, the rest of the retina is stabilized and the macula is fine. So basically, this is a case of a full-term baby having proliferative retinopathy. So most likely a case of FEVR. Why we are seeing most likely? Because we did not do a genetic workup. So as we all know, FEVR is a dysfunctional retinal angiogenesis resulting in avascular peripheral retina with resultant neovascularization and its subsequent sequelae. Commonly seen in full-term children, however, sometimes they can overlap an ROP in a preterm when we call it ROPER. So a positive family history helps in the diagnosis. However, a negative family history does not negate the presence of FEVR. They are genetically heterogeneous and even the phenotypic presentation varies a lot from asymptomatic peripheral retinas to tractional RDs causing severe sight loss. So the conclusion is that FEVR, we should bear in mind that FEVR is an important cause of sight loss in full-term infants, and infants with multiple comorbidities admitted in the NICU should preferably undergo an ophthalmic examination early on in life. A multidisciplinary team approach, which actually helped in this child's case, with the presence of an alert neonatology team is extremely important because the mean age of presentation with visual defects for a child with FEVR is around 4.5 to 5 years. And also FEVR, another take-home point is that FEVR has a persistent course. So we need to make sure that the child is followed up, unlike ROP. Thank you.
But if you are diagnosing it as FEVR, do you suggest anti-VEGF?
So ideally it should only be lasered in FEVR, but because of the persistent vitreous hemorrhage and the unstable clinical status of the child at that time who couldn't undergo a surgery, so that is why we injected. Yes, actually a very important question.
Ma'am, one thing that usually we in ROP we ask after 4 weeks.
Yes,
but
yes.
in this case,
This
it
is
isn't.
just, I would say the child was blessed and they noted a red reflex because of that existing hemorrhage. So it was not part of our usual ROP screening. It was like an emergency call, there's a red reflex, and so the child was lucky and the team was observant.
What do you suggest? At what time should we, with a child with
No, if we have
multiple comorbidities?
So again, I think similar to ROP at 3 weeks, but if somebody has a coagulopathy, then maybe earlier because they may even have vitreous hemorrhage without the presence of a proliferative retinopathy.
Thank you.
Thank you so much.
Next presenter, Dr. Vijay Kumar Maurya.
Good afternoon, everyone. My topic is role of topical dorzolamide in the management of increased central macular thickness in patients of chronic central serous chorioretinopathy. Chronic central serous chorioretinopathy is a retinal disorder characterized by the accumulation of fluid beneath the retina, leading to an increase in central macular thickness. This condition often results in visual impairment, which is more commonly observed in individuals aged 20 to 50 years. The pathogenesis of CSCR involve the dysfunction of retinal pigment epithelium and the choroid, leading to the leakage of fluid from the choroidal vessel into the subretinal space. While the acute CSR may resolve spontaneously, chronic or recurrent cases can lead to persistent macular edema, which is a major cause of visual deterioration. Current treatment option for CSCR is limited, with focal laser therapy, anti-vascular endothelial growth factor injections, and photodynamic therapy being some of the modalities. However, these treatments do not always lead to satisfactory outcome, especially in chronic cases where macular thickening persists. In this context, the role of topical therapies, particularly dorzolamide, has gathered interest. Dorzolamide is a carbonic anhydrase inhibitor, is widely used in the treatment of ocular conditions such as glaucoma and ocular hypertension. It works by reducing the production of aqueous, thereby decreasing intraocular pressure. Recent studies suggest that dorzolamide may also have an effect on macular edema by altering the balance of fluid in the retina. The aim of this research is to know the potential role of topical dorzolamide in the management of increased central macular thickness in patients of chronic CSR. By examining its efficacy, reducing macular edema, and improving visual acuity, this study seeks to contribute to the understanding of alternative therapies strategies for CSR and to provide evidence for the use of topical dorzolamide, a potential treatment option. The aim of the study was to check the therapeutic effect of topical dorzolamide in patients of chronic CSR, and the primary objective was is to decrease central macular thickness and to evaluate safety and efficacy of topical dorzolamide in patients of persistent macular edema. And this was a prospective controlled interventional study at Tertiary Care Hospital, RIU Prayagraj, after taking ethical approval and consent from the patients. Inclusion were the patients who were diagnosed with chronic CSR, persistence of subretinal fluid for more than 6 months by using OCT and the fundus fluorescein angiography. Exclusion criteria were previous history of intraocular injection like anti-VEGF injection, focal laser therapy, and photodynamic therapy. And the CSR associated with other ocular conditions like diabetic macular edema, ARMD, choroidal neovascularization, tumor, retinal vascular occlusion, retinitis pigmentosa. And patients with severe systemic disease like malignant hypertension, end-stage renal disease, pregnancy, and weight loss are also excluded. And patients with follow-up less than 1 month are also excluded. And the patient not responding to topical dorzolamide at the end of 1 month with less than 10% reduction in CMT were also excluded. The mode of intervention, the controls were observed with topical carboxymethyl cellulose 3 times a day, monthly, with base corrected visual acuity, subretinal fluid, fundus fluorescein angiography, and central macular thickness on OCT. Whereas confirmed cases were treated with topical dorzolamide 2% 3 times a day for 3 months and followed with the same as controls. The patients were followed monthly for 3 months for the improvement and further followed for 9 months. And the results were checked after 3 months. In demography, maximums were males, and the maximum patients were in the age group of 31 to 35 years, and most cases were the unilateral. And in cases at the end of 3 months, we observed an average reduction of minus 236 micron of central macular thickness, while in controls, we observed at the end of 3 months, the average reduction was 39. In cases, the patient improved were 76%, while there was no improvement in 3 patients, and in controls, the improvement observed in 23% of the patients, while 10 were not responded to the treatment. And the ocular side effects observed were very least, only burning sensation in 1 patient and redness in 1 patient. Discussion: the patient who received topical dorzolamide 2% had greater reduction in central macular thickness as compared to the patient who were only observed at the end of 3 months. A higher proportion of patients treated achieved the complete resolution of subretinal fluid. That is, in cases it was 76%, while in control it was 23%. Base corrected visual acuity also improved significantly, 2 to 3 Snellen lines from the baseline in cases, while it was 1 to 2 lines improvement in the observed cases. This was not significant. And the similar studies which were reported, these are Vedavi et al., Gerald Levy et al., and Agrawal et al. Conclusion: topical dorzolamide 2% results in a significant improvement of base corrected visual acuity and more rapid reduction of mean central macular thickness at 3 months post-treatment in treated cases compared to observed. It suggests topical dorzolamide may be a viable adjunctive treatment option for patients with chronic CSR. It can be used as an effective, affordable, and safe adjunctive therapy for treatment of chronic CSR. Thank you.
Thank you. Your exclusion criteria is 1 month of dorzolamide if they do not show improvement?
If they're not going to, if the reduction of CMT is less than 10% from the baseline, the
Okay.
patient was included and moved on to the current treatment like focal therapy, photodynamic therapy.
Okay. Okay. Thank you.
Thank you.
Next presenter, Dr. Priyanshi Priya, is she here? Please come to the dais. I would request Dr. Nikita to be ready. Is she here? Dr. Nikita,
Yeah.
you can come to the other side.
Good afternoon, everyone. I am Dr. Priyanshi Priya, Senior Resident, KGMU, Lucknow. I am here to present my talk on the topic Tale of Three Intraocular Foreign Bodies. Objects that penetrate the eye, logic within its internal structures, are known as intraocular foreign bodies. The common causes being occupational injuries, explosions, and projectiles. Associated risks are vision loss, infection, retinal detachment, sympathetic ophthalmia. Ocular injury caused by an IOFB depends upon its velocity, size, nature, entry site, and impaction. Radiological investigations are essentials for detection and localization. Depending upon the nature and location of IOFBs, the treatment strategy is planned. Goal of surgery is to prevent further damage and restore ocular anatomy, while functional restoration of vision gain is the secondary goal. Here are some of the pictures which show that foreign bodies can be impacted anywhere in the eye, from anterior segment, vitreous, to subretinal or retinal surface near the optic disc, on the macular area, or in the periphery, which determines its treatment strategy and prognostic outcomes. So this is a story of a young male with a history of trauma by nail hammer injury who presented to us with a complaint of blurred vision. On detailed history and examination, we found 3 limbal sutures with a suture granuloma at 3 o'clock site with media haze due to traumatic cataract and dense vitreous hemorrhage. On radiology, we found a radio-opaque foreign body in the intraocular cavity. So we planned a surgery doing traumatic cataract extraction, and on clearing the media, clearing the vitreous hemorrhage, there was a impacted fibrosed foreign body over the macula. So instead of causing much harm to the patient than benefit, the decision to remove the foreign body was abandoned. So the visual outcome was affected and it did not improve much. A similar case of a young male with a history of trauma to right eye presented with a complaint of blurred vision. He had, on examination, we found a sealed corneal tear at 7 o'clock position with the traumatic cataract. In the radiology, a radio-opaque material, hyperechoic material was seen inferiorly over the surface of retina. On cataract extraction, we found a pre-existing central posterior capsular tear present, and with the help of intraocular foreign body magnet, we retrieved the foreign body which was present over, near the vascular arcade through the posterior capsular tear via the anterior segment route through the corneoscleral tunnel made for cataract surgery. IOL was implanted and silicone oil installation was done, and 6 months later, oil removal surgery was done. Thus, the visual outcome improved significantly to 6/9. These were the instruments used, and foreign body was retrieved, as shown in the picture D. Thirdly, a young boy with a history of a similar trauma to the right eye presented with a complaint of blurred vision. There was a similar corneal opacity, sealed corneal tear present at 2 o'clock position and iris defect posterior to it. In the radiology, a foreign body can be seen in the midvitreous cavity. In the surgical plan, we extracted the cataract, traumatic cataract, and upon clearing the media, a foreign body was seen impacted along the vascular arcade. So with the help of intraocular foreign body magnet and forceps, it was tried to retrieve through the pars plana route, but due to its shape and size, this was not possible. So we made a sclerotomy at 10 to 11 o'clock position, and the foreign body was retrieved through that. Later, silicone oil, laser retinopexy was done, silicone oil installation was done, and oil removal. So we compare 3 case scenarios of patient where sites of impaction of foreign body and the surgery affected the visual outcome. In the first case where the foreign body was left, visual outcome was finger counting close to face. In the second case where it was retrieved through the anterior segment route, it improved to 6/9. And in the third case where it was retrieved through sclerotomy route, the vision was 6/18. So different surgical challenges are encountered depending upon the nature, location, and site. Better outcome was obtained where IOFB was retrieved. Thank you.
Thank you, Dr. Priyanshi.
Thanks.
Thank you. Next presenter, Dr. Nikita. Dr. Sumit Patil, is he here? Dr. Sumit Patil. Dr. Avnish Upadhyay. Dr. Jitendra Kumar. Okay, you can start.
Good afternoon, everyone. My name is Dr. Nikita. My topic for today is snake-like pattern on retina, that is serpiginous choroiditis. This one move ahead. Move. Sorry. Okay. Serpiginous choroiditis is an inflammatory disease characterized by geographic pattern extending from the peripapillary area, that is from the optic disc, up to the RPE and outer retina in a centrifugal manner. It is recurrent and progressive in nature. It is responsible for less than 5% of the posterior uveitis cases, commonly seen in young middle-aged adults, and the male predilection is more common than female, and it has bilateral presentation as well. It may be infectious or non-infectious, and in infection it is associated with syphilis, tuberculosis, herpes, and might also be associated with HLA-B7. The main etiopathogenesis is the involvement of the RPE, the outer retina, and the choriocapillaris. Incidence in India is approximately 5 to 8%. We present a unique case of a 28-year-old male who presented to OPD with complaints of diminution of vision in both eyes since few months. Patient had no other complaints than diminution of vision. There was no history of systemic illness and no history of ocular trauma or previous surgeries in the past. But patient had a past history of tuberculosis, which was approximately 6 years ago. On clinical examination, the visual acuity of right eye was 6/18, improving to 6/9, and of left eye was 6/60, improving to 6/18. EXOM were free full paleness in both eyes, and the anterior segment examination of both eyes was within normal limits. On posterior segment examination of right eye, the media was clear. Optic disc showed peripapillary atrophy with CD ratio of 0.4:1 CTR, along with temporal pallor. AV was attenuated, FR was dull, and the macula showed old choroiditis patch extending superotemporally and inferonasally along the vascular arcade and extending in a serpiginous manner. That of the left eye, the media was hazy. The optic disc showed peripapillary atrophy along with temporal pallor, and the macula showed tractional bands along the superior temporal arcade involving the macula. The lesions were well circumscribed, grayish-yellowish lesions suggestive of chorioretinal atrophy. Few healed atrophic lesions were also present, which were in a geographic pattern extending towards the macula, involving the fovea and the parafoveal region. This is the fundus photograph of the patient. Laboratory investigations were within normal limit. The patient had no evidence of any active infection, and patient was treated with oral steroids and immunosuppressive therapy was given. Patient was advised refraction and was counseled for follow-up after a few weeks. The main treatment goal is to suppress active inflammation and reduce the recurrence rate. A combined regimen of corticosteroids and immunomodulatory agent is very important, along with adjunctive treatment with anti-angiogenic factors. The most likely hypothesis behind serpiginous choroiditis is that it has an autoimmune correlation or might be idiopathic in nature, when not related with any systemic or infectious cause. The most common complications could be either choroidal neovascularization, cystoid macular edema, branch retinal vein occlusion, optic disc vascularization, or serious retinal detachment. In chronic long-standing cases, long-term treatment is required with steroids and immunosuppressive agents. The patient usually has a poor outcome in such cases. I would like to conclude that based on clinical findings and investigations, 28-year-old male with bilateral posterior segment findings without any other present systemic illness is a case of bilateral serpiginous choroiditis. The findings were confirmed with fundus photography and OCT. Follow-up was advised to the patient after a few weeks. Thank you.
I would like to ask, did the patient had any active inflammation? Because the fundus photo was showing there were scarring all over there.
Ma'am, there was no active inflammation. The patient had a past history of tuberculosis 6 years ago.
Then why did you treat him with the oral steroids and immunosuppressants?
Ma'am, earlier in the fundus photo of the right eye, according to the faculty that I had shown, they were of the opinion that patient didn't have active lesions. But on further routine examination, we found out that those were just the choroatrophic patches.
When the patient is having healed choroiditis, I don't think we should treat him with oral steroids.
Ma'am, the patient had a past history of arthritis as well. So because of that,
So he
ma'am.
must be having some medical treatment for arthritis.
Yes, ma'am. So, ma'am, we had referred the patient to the rheumatologist. So, according to that, they started the patient on oral steroids, ma'am.
Okay.
How can you confirm or differentiate between active and the healed lesion by doing any investigation?
So, we had an option of fundus fluorescein angiography as well, but the patient was not giving consent for the same. So, we couldn't.
Anything apart from FFA which you can do to differentiate?
So, based on the lesions also, like the margins of the lesions would be more enhanced and would be elevated, and as compared to the active lesions would be present at the periphery of the old scar.
Does autofluorescence have any role?
Yes, sir, it does.
Do you have that in your institution?
Sir, we did not, so we couldn't perform it.
We can
Thank
do follow-up of these patients by autofluorescence also.
Yes, ma'am. Ma'am, actually, we eventually, in a span of a month, we lost the patient to follow-up because the patient was originally from Bihar. So, on a routine OPD examination, we diagnosed this, and then afterwards, in a period of a month, we lost the patient to follow-up.
Thank you.
Thank you.
Dr. Sumit Patel, is he here? No. Dr. Avnish Upadhyay? Dr. Jitendra Kumar? Dr. Purva? Please come on the dais.
Good afternoon, everyone. The title of my study is Pneumoretinopexy, a 9-year retrospective study at a tertiary care hospital. So, pneumoretinopexy is a technique for the repair of selected cases of rheumatogenic retinal detachment. It is done by injecting an expandable gas and applying retinal cryotherapy or laser photocoagulation to seal the retinal breaks. There is an increase in popularity of PNR as it has been proven to be a safe and effective procedure with good success rate. So the purpose was to study the outcomes of failed PNR in a tertiary eye care hospital. We included cases of RRD who were treated with PNR between January 2015 to June 2024 in a tertiary care hospital. This was a retrospective study. These are my inclusion and exclusion criteria. So we recorded patient demographics like age, gender, lens status, the type of gas used for PNR, retinal status following PNR. In cases with failed PNR, we recorded the cause of failure, further follow-up and treatment, delay between advice and the second intervention, the final surgical outcome following subsequent therapy, and final BCVA. Final BCVA between cases with successful and failed PNR were compared. Comparison between visual acuity was done by Mann-Whitney U test, and categorical data analysis was done using chi-square test. So 52 eyes were included, mean age being 53 years. And we saw that there was no significant association between age, gender, preoperative status, and the tamponading agent used for treatment failure. About 50% patients had attached retina following PNR, while in 50% patients the retina was not attached. The causes for failed PNR were studied, and missed break was the commonest cause noted. So these 26 patients were advised additional surgeries, out of which 3 patients lost to follow-up. And after additional surgeries, we saw that 69% patients had finally attached retina, 4% patients did not have attached retina, but 27% patients lost to follow-up. The visual acuity was compared, and it was seen that patients with retina attached after PNR had better visual outcomes than those who required an additional surgery. The delay between time of advice and secondary intervention, as it increased, there was a reduction in visual acuity. Thus, we saw that PNR is a simple technique for the repair of selected cases of RRD, which has reported an anatomical success rate between 43.7 to 93.5%. Patients' compliance to position and proper case selection are the most important factors. 50% patients had attached retina, 27% patients lost to follow-up following failure, and a significant delay between advice and secondary procedure was seen, which correlated negatively with the final visual acuity. The cause of delay could not be recorded because it was a retrospective study and it was not documented in our medical records. So we conclude that though PNR is a simple and effective procedure, limiting factors in our settings would be failure to follow up and delay in second intervention, proper preoperative examination and preoperative counseling regarding need for positioning, follow-up and immediate resurgery is essential. The exact cause of failed PNR could not be determined in all our cases, and cause for delay between advice and additional procedure and failure to follow up could not be determined. These are my references. Thank you.
PNR is not a simple procedure, actually. You need lot of patient counseling, and patient selection is very important.
Yes, ma'am.
And what was your inclusion criteria?
Ma'am, patients above 18 years of age we had selected, and who had a rhegmatogenous retinal detachment was selected, mostly having a single break in the superior quadrant.
Any lens status you kept in mind?
No, ma'am.
Phakic or pseudophakic?
No, ma'am.
Because hidden breaks are very common. So patients, they do require sometimes second surgery. So it's not that simple.
Yes.
Okay.
Thank you.
Next presenter, Dr. Kajal. Is she here? Please come on the dais.
Good afternoon, everyone. The title for my presentation is Predictors of Visual Acuity Post-Vitrectomy for Rhegmatogenous Retinal Detachment. The incidence of RRD is 0.01% and pars plana vitrectomy is one of the procedure for retinal reattachment. Silicone oil, gas or air are used as intraocular tamponade agents following vitrectomy to achieve apposition of break to retinal pigment epithelium. The purpose of this study was to evaluate the predictors of visual acuity after vitrectomy with silicone oil tamponade for macula of RRD. It was a retrospective study during the period April 2023 to July 2024, and the details of the patients were recorded at 1 week, 4 week, and 12-week follow-up. These were my inclusion and exclusion criteria. Baseline parameters such as age, gender, lens status, duration of detachment, alum peeling performed or not, and the type of subretinal fluid drainage was noted. Complete ocular examination details were collected, and the OCT was performed with Topcon DRI OCT Titan Plus, with radial 9 mm with overlap 16 protocol centered on fovea was used. Outer retinal parameters like EZ integrity, ELM integrity in the central 1 mm zone and the central foveal thickness at 1, 4, and 12-week follow-up were noted. EZ was graded at grade 1, which was normal and continuous, grade 2, patchy thinning and continuous, grade 3, continuous thinning and continuous, grade 4 as discontinuous, and grade 5, in which EZ was absent. ELM was graded as grade 1 continuous, grade 2 discontinuous, and grade 3 absent. Visual acuity values were converted to decimal. Comparison between the period was done by ANOVA and Bonferroni post hoc test. Pearson calculator was used for correlation, and p-value less than 0.05 was considered as significant. So we noted 43 eyes. Mean age was 52 years, and majority were male. In two-thirds of the patient, PFCL-assisted drainage was done, and ILM peeling was not performed in two-thirds of the patients. Mean visual acuity improved from 1 week to 12 weeks significantly. Median EZ and ELM integrity was also improved significantly. Central foveal thickness was increased. 18% developed macular edema. Baseline parameters, there was no significant relationship between the age, gender, lens status, type of drainage, whether ILM peeling performed or not, with the final visual acuity and EZ and ELM grading. We noted 72 days as the mean duration of detachment, and we noted that longer duration of detachment was associated with worse visual acuity outcomes. In PFCL-assisted drainage, the mean central foveal thickness was more. OCT parameters, strong positive correlation was noted between EZ and ELM grade, and as the ELM grade improves, EZ tends to improve as well. Negative correlation was noted between EZ integrity and mean visual acuity, and between ELM grade and mean BCV also negative correlation was noted, which was significant at 4th week. Coming to discussion, best corrected visual acuity and OCT parameters improved significantly over 12 weeks post-surgery, and they were not affected by baseline parameters except for the duration of detachment. Central foveal thickness increased over 12 weeks, more in the PFCL-assisted drainage group, which could be due to macular edema, epiretinal membrane, and can also be due to restoration of the outer retinal layers. Limitation, it was a retrospective study with a small sample size and lesser duration of follow-up. So I want to conclude that EZ and ELM integrity helps in knowing the visual prognosis post-surgery. Drainage technique and ILM peeling do not affect outer retinal integrity, and further prospective studies should be done with a large sample size and longer duration of follow-up. These are my references. Thank you.
Thank you.
One thing I would like to ask, did you have some selection criteria for the patients for ILM peeling? Because in some patients you did the ILM peeling and in some you didn't do it.
No, ma'am, like it was the surgeon call only, like.
Okay, it depends on the surgeon.
Yes,
okay. Thank you.
Thank you.
Dr. Vidush Ratan. Dr. Vidush Ratan is here? No. Dr. Anvisha Banerjee. I think she is also not present. We are done with the
So we conclude the session here, and we can have a group photograph with the speakers who are all present here.